Good evening, everyone. I am Dr. Mazhar Zulfikar. I am second year PG resident from Malabar Medical College.
Myself, Dr. Bijina Baradan, second year PG resident, Malabar Medical College.
And they are the first batch of their postgraduate from the Malabar Medical College. Okay, we will start.
Discussion today is benign prostatic hyperplasia for TURP surgery, transurethral resection of prostate. My case is 68-year-old male carpenter presented with complaints of increased frequency of urination, dribbling of urine, sense of incomplete bladder emptying, and weak urine stream for the last 6 months. He had acute, 3 weeks back, he had acute retention of urine and was catheterized from a local hospital and Foley's in situ and was referred to our urology OPD the next day. He is not having any significant comorbidities. He is not addicted to smoking or alcohol. Sleep, appetite, and bowel habits was normal and no relevant family history.
Right.
General examination, he is conscious, oriented, and cooperative. He is afebrile, normal built and nourished. His BMI is 21.2 kg per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Vitals, his pulse rate is 78 per minute, regular, normal volume and character. BP is 130 by 84 in supine and 122 by 80 in standing position. Respiratory rate is 14 per minute, which is regular and abdominothoracic. Saturation is 98% at room air and JVP is not raised. Airway and spine examination, airway is normal and spine examination, it is normal alignment. Spinous process and the interspinous space was visible and normal, which was not having any tenderness. Summary, it is a 68-year-old carpenter, no significant comorbidities, urinary complaints for the past 6 months, and he was catheterized 3 weeks back for acute urinary retention. His general condition is fair, normal airway and spine examination, all other system were within normal limits. He's diagnosed to have benign prostatic hyperplasia, and he is posted for transurethral resection of prostate.
So, how are you going to prepare this patient for surgery and anesthesia management?
First of all, there is some anesthesia concerns with the benign prostatic hyperplasia. It occurs in the old age, so geriatric is a major concern of this surgery. Second one, this surgery will be done in the lithotomy position. So the position, anesthesia concerns for the lithotomy position and surgery and surgical related complications. So first, we have to
investigate and evaluate preoperative investigation, and how do you optimize the patient?
In this patient, patient is not having any significant comorbidities, and
What's the age of the patient?
Patient is 68-year-old male.
Would you like to do some investigation before taking up this patient?
Yes, sir.
So
First,
what investigation would you like to have for that?
first I will like to do CBC. There is a complete blood count, which will include hemoglobin to rule out any anemia, and total blood count because the patient is catheterized. Patient can have urinary tract infection, so I have to rule out that. And also the platelet count, if the thrombocytopenia is there, if it is less than 50,000, we usually prefer regional block, so it will be a contraindication. Then I will like to do the serum electrolyte to rule out any hyponatremia in this patient, and also I will like to do the coagulation profile, then serology as a routine. Then chest X-ray will be taken, and ECG, and since this patient is in old age group, I would like to do a 2D echo to rule out any cardiac compromise in this patient, because there is a chance of volume overload during the surgery. So the patient's ejection fraction, and also there any regional motion abnormality to be ruled out. Then I will also
baseline renal function test, urea creatinine we would like to see, because the patient was having acute retention and it will increases the urea creatinine and alters the renal function test.
You said the patient has been put cathetered. What is the significance of that?
Catheterization is basically the patient's one of the factors. The catheterization, it is a chance for infection is there. So any pre-existing urinary tract infection can cause transient bacteremia and septicemia in the patient during the procedure. And also, while catheterization, the hyperemia and congestion of gland will be there. During surgery, the chance for bleeding is also more in a catheterized patient. The third one is it will improve the obstruction and it will makes the renal function test, it will normalizes if the obstruction is relieved.
So when do you take up this patient for surgery and anesthesia?
Anesthesia. If the patient is not having any active infection and all the pre-op investigation is normal means I can take up the patient.
So this patient is having, he's of 68-year-old carpenter. He's still doing his carpenter work. So what about his exercise tolerance?
By history, we will ask about the exercise intolerance, his physical activities, and we can assess the METs of the patient, metabolic equivalency of tasks. We can assess the patient, and if it is normal means we can assume that the functional activity of the cardiopulmonary reserve will be good for the patient.
He's not a smoker.
It's not a smoker, sir. No addictions.
You said about the geriatric issues. What are the changes or physiological changes there in geriatrics, and what precautions you will take?
So in this patient, during aging, there will be changes in every system. So in a CNS system, central nervous system, there will be a decreased functional tissue, and the patient also will have confusion and dementia can be there. So it is also a factor because during the surgery and positioning, we have to convey regarding that to the patient. So before the surgery, we have to know the cognitive function of the patient. Then in the peripheral nervous system, it is super sensitive. So the drug dosage should be adequate. Then in the cardiovascular system, there will be hypertension. I mean, due to the vessel wall thickening and increased peripheral vascular resistance, there will be systemic hypertension, and also a diastolic dysfunction will be there. Then the sclerotic.
The baroreceptor function of the patient will be poor, so the hypotension which followed by the regional techniques as spinal anesthesia and all will not be tolerated as a young patient. And
Technique of regional anesthesia, spinal epidural.
So we have general and regional anesthesia. The regional anesthesia we have spinal, epidural, and combined spinal epidural.
What is the problem in doing these techniques in this age?
This due to stiffening of the joints and the cartilages, musculoskeletal system weakening. The positioning and the epidural technique will be difficult in the geriatric population.
About the predicted level of anesthesia?
So predicted at to T10.
Why do you say it is up to T10?
So the level, the nerve supply is from T11 to L2, and the patient, if it is above T10, the one of the complication is bladder rupture. So if there is bladder rupture happen, patient will have referred pain, and if the level is above T10, a patient won't have clinically. I mean, patient won't complain about pain, and there will be delay in diagnosing.
If it is less than T10 means the patient will be having difficulty during the distension of bladder, because the bladder supply will be from T11 to L2, so the adequate level is considered as T10.
Okay, during the preoperative visit to this patient, what all things would you like to discuss with the patient?
Since he is old age, he will be anxious about the surgery, and also I would like to.
Anxiety is only in old age?
No, sir.
Since it is old age, you will be anxious. So you people will not be anxious when you are going for surgery. Okay.
Old age, their vision, hearing, and all will be a problem. So they won't be. If we do not communicate properly, means they will be having the confusions regarding. So I'll make a good rapport with the patient. I will explain about the plan of anesthesia and the surgery details and NPO guidelines. I will tell to the patient. And adequate NPO should be done because those patients will be very prone for the hypotension. So prolonged hours of fasting can cause hypotension in the patient.
And also informed written consent will be taken, and I will also inform regarding the common complications and about
The natural question the patient will ask, how are you going to anesthetize? എന്നെ ബോധം കെടുത്തു, എനിക്ക് വേദന ഉണ്ടാവുമോ? That's what they are going to ask.
So I will explain about the method of anesthesia. That is, regional anesthesia will be given. There will be about the positioning and also
What is the choice of regional anesthesia in this?
the spinal anesthesia will be the preferred.
Why not
He's-
epidural?
He's old age and anxious. He will tell, no, don't prick me in my back. He will tell.
So I will explain the complications to the patient and why the spinal anesthesia is preferred. So we will explain and counsel the patient.
And geriatric patients, sometimes they may be disoriented, confused, and especially with the bladder catheter, they will not be able to comprehend what you are telling. So you may have to take the support from the.
What about the epidural? You said you will choose the spinal. Why not the epidural?
So epidural can cause sacral sparing. So the patient may complain about pain during surgery. So I will prefer spinal. It is a simple technique and there will be dense anesthesia. And also it will, the surgery is not more than 1 hour. So it will provide a prolonged anesthesia, and also post-operative pain also will be reduced with this.
What's the problem in using general anesthetic technique in this patient?
So
General anesthesia, the primary problem concern we are expecting, or the complication we are expecting, will be due to the absorption of the irrigation solution. So the mentation we will be able we won't be able to find out the earlier symptoms of the TUR syndrome or due to absorption of the irrigation solution. That is, the patient's mentation we won't be able to assess. And
And also due to the spinal anesthesia, there will be reduced blood loss. So we can decrease the blood loss during the surgery when compared to general anesthesia. And also post-operative analgesia will be there with the spinal anesthesia, which will lack in general anesthesia.
What are the intraoperative problems you are going to anticipate in this procedure?
First one is due to the absorption of the irrigation solution. Second one, hypothermia, which is due to absorption of the room temperature irrigation solution, and also the thermoregulation will be impaired in the old age or geriatric population. So hypothermia is a concern. Then intraoperative, since the prostatic tissue is highly vascularized and blood
You
rich.
talked about irrigating. Which are the common irrigating fluids used in which one do you prefer?
In our institute, we are using 1.5% glycine.
What advantage and disadvantage of that?
The advantage is its osmolarity is 220. It is coming near to the normal range. So the complication of hemolysis due to highly hypotonic solution is prevented, and also it is not that it is transparent, and the vision for the surgeon is also good for glycine. Third one.
What are the disadvantages? Any disadvantages?
So glycine, it is an inhibitory neurotransmitter to the brain and spinal cord. So when the glycine is used, it can cause it can cause inhibition, and also the one of the metabolite is ammonia, and due to increased ammonia level, it can cause hyperammonemia, and there can be encephalopathy in this patient, and also transient blindness due to glycine, which acts on the retinal cells.
Which are the other fluids used?
Other fluids are distilled water, urea, mannitol, cytol, sorbitol.
What are the features of an ideal irrigating fluid in this surgery?
It must be isotonic, and it must be when it is metabolized, it should, it is non-metabolized, and
It should be inert, it should be non-electrolytic, it should be easily cheap and easily sterilizable,
transparent and
isotonic, transparent.
So you have chosen glycine. The glycine, you said the osmolarity is how much?
220 for
220.
1.5.
What is the normal osmolarity?
275 to 290.
So why don't you increase the percentage of glycine? Why can't it be 2%?
The solution will be too turbid and it will affect the vision of the surgery. So if we increases the percentage of glycine, transparency will be impaired.
What about the chance of bleeding in this procedure?
Sir, since the prostate is supplied by the high, it is having capsule out, that is venous plexus outside the capsule, and it is having rich blood supply. The chance of bleeding is very increased, and also due to recent catheterization and all, the gland will be hyperemic or congested. The chance of bleeding will be increased. And we are using the procedure itself will be cutting and coagulating the bleeding when capsular perforation occurs, means bleeding will be perfused.
So how do you assess bleeding in this procedure?
So we can use a colorimetric method. Then colorimetric method, we will quantitate there is an equation. The amount of blood loss is equal to the hemoglobin and the irrigation fluid by patient's hemoglobin into volume of irrigation fluid used, and by using that we will assess the blood loss. And
What is the position used for this surgery?
lithotomy
Lithotomy
position, sir.
with a slight Trendelenburg
What's the problem of this position? Does it cause any problem for the anesthesiologist?
So lithotomy position, there will be a
Lithotomy with, you added something, along lithotomy with the,
slight
mild Trendelenburg position.
so you have to tell both. Lithotomy with,
first in geriatric population due to
no, just tell about the problems during the procedure with this positioning.
So there will be a cephalod shift of diaphragm. Which will reduce the functional residual capacity, residual volume of the patient, and if it's also cause a venous return to
Injuries
the
it causes? Any
peripheral,
injury?
Peripheral nerve injury
injuries
can-
due to position.
Which are the nerves involved in this?
The commonly affected nerves are obturator nerve, femoral nerve, common peroneal nerve, and saphenous nerve. Saphenous and common peroneal around the lateral portion of the leg due to we are using knee strings, and by flexion of the hip the obturator and femoral nerve can get compressed.
So how do you prevent or minimize these problems? Because it can lead to litigations after anesthesia.
Adequate padding should be done towards the pressure points in knee joint and all. And the position should not be, adequate position should be given. Hip flexion should be 80 to 100%, not more than that. And the
Can it cause any other complication, that position?
position, then it can lead to venous stasis in the lower limb. So in old age, they are more prone for DVT and all. So this position also will cause. But since the duration of surgery is less, means the risk is
So what
prevented.
do they say? What the scientific data say, that how much time, like if it is more than how much time, like you'll have to use this?
More than 3 hours to
No, if it is more than 15 minutes, then you'll have to definitely use this. You said the complications, a few other complications, like one of the complication you said was TURP. Okay, can you explain about that?
it is caused.
Or how will you assess, like how will you know if you are given spinal anesthesia or if you are given GA?
In spinal anesthesia, since we can assess the mentation of the patient, the earlier symptoms will be the patient will become restless and agitations will be there. And the vitals, if we see, first it will be hypertension followed by the reflex bradycardia, and hypertension will be followed by prolonged hypotension in the patient. And then the patient can have, if the circulatory overload occurs and pulmonary edema features occurs, means we will have CRUPS, the saturation will be decreasing for the patient. The patient will complain of breathlessness. Then nausea, vomiting will be there due to hyponatremia.
During general anesthesia, the patient can't patient will be unconscious. So the monitors, we will check the monitors to diagnose the symptoms. There will be, as he said, there will be a bradycardia. First, initially, there will be hypertension followed by hypotension. There will be ECG changes according to if there is a broadening of, initially there will be broadening of QRS complex followed by ST elevations, and if the serum sodium drops beyond 110 milliequivalents per liter, it can result in ventricular tachycardia or fibrillation, which can seen in the monitor.
Should not allow the patient to go to ventricular tachycardia and ventricular
No,
fibrillation.
sir. Before that, we will
You
tell
should
them.
not wait till that time. So, as an anesthesiologist, what precautions could you should have you could take to prevent a patient going to ventricular fibrillation and all? You should from right from the beginning. How do you detect it early, and how can you can prevent its progression? And once it occurred, how do you treat it?
The earlier phase itself, we have to detect the TUR syndrome by seeing the altered mentation, restlessness, nausea, vomiting from patient history, and the vitals change.
History? What history?
That is that nausea, vomiting, or patient's complaints.
So what should you do? That's
Immediately terminate the procedure.
Huh?
Immediately terminate procedure by telling the surgeon
Ask the
regarding,
surgeon to stop it and go,
no,
stop the procedure.
We have
and
to
send a
tell-
serum.
You have to tell the surgeon that this complication is likely to occur, so you have to finish it as soon as possible. You have
It
to.
will be better term than stop the surgery and go out to the theatre. Don't tell in such drastic ways, at least in Malabar Medical College.
What are the precautions you will take?
Questions,
Means like after it has occurred, how are you going to manage?
uh,
And
first-
also the precautions, like what is the rule of 60?
The precautions, first, that the intravesical pressure, that is the height of the irrigation solution, should be less than 60 centimeter from the pubic symphysis, so as to decrease the intravesical pressure, and it will decreases the absorption of the fluid. Second one, the maximum tissue resected should be less than 60 gram, and also the duration of surgery is also matters. So we have to restrict the duration of surgery to less than 60 minutes.
And meanwhile, you can send the serum samples for
Sodium.
Serum electrolyte.
and how do you correct the sodium?
So the correction, will be less than 1 millimole per liter per hour within 24 hours.
If the patient is not having any symptoms, or if the sodium level is more than 120, means no correction is required. If the patient's serum sodium is less than 120, only correction should be initiated.
Surgery is over and the patient shifted to theatre. Patient become restless, heart rate increases. What all things will you look for?
So it can be due to pain, then clot retention, then it can also be due to TURP syndrome. So first we have to diagnose the reason for that. So if the pain, adequate analgesia, the clot retention, if the clot retention is there, we have to flush the catheter and relieve that. Then if the patient is if it is due to TURP syndrome, we have to treat it accordingly.
How do you label it as TURP syndrome?
So it can it can start within 15 minutes of surgery to up to 24 hours of surgery. If the patient is
24 hours in the recovery room, how do you diagnose TURP syndrome?
the patient
Post-anesthesia care unit, PACO.
Patient will be having confusion, irritation, and all. We will send
He's
the
asking about TUR syndrome. It's not clot retention. He's asking, will you assess if the patient is already conscious? So, what are the things? That's what he has asked.
Or what are the features of florid TURP syndrome? In the florid features, patient has finished surgery, given fluids in the recovery room, the patient. How do you diagnose TURP syndrome in the post-anesthesia period?
The patient will be having symptoms of hyponatremia.
What symptoms?
The patient will be agitated, restless,
symptoms of hyponatremia.
will be restless, confusion, agitated, nausea, vomiting will be there. Then we have to send the sample for serum electrolyte, serum sodium. We have to see the level of serum sodium. And,
Pulmonary
then,
edema can be the
What about chest signs?
if the
Crepitations
pulmonary
will
edema
be
is
there.
there, crepitation will be there.
Saturation.
Saturation will
fall-
fall down.
It can
What
decrease.
will you do immediately?
The oxygenation, give oxygen and
Propped
propped up the position.
Will you give any drug?
Loop diuretics like furosemide can be given to decrease the pulmonary congestion or
What are the indications for intubation and mechanical ventilation in such cases? When do you intubate these patients?
if the patient saturation is not improving with the oxygen supplementation or propped up position or IV loop diuretic injection, saturation is falling means we have to think of intubation and mechanical ventilation.
Do you give any other diuretic for this?
Diuretic 20% mannitol can also be given because the patient will be having hyponatremia, so Lasix can increase the, that is, it can also cause hyponatremia, so mannitol can also be
In
used.
the exam, please don't tell Lasix. If that company stops producing
Furosemide.
Lasix, what will you do?
Furosemide.
Will I have to get furosemide from some other company also? Okay. What are other complications that can occur during this
Other
procedure?
complication is hypothermia due to irrigation with the room temperature irrigation solution. Second one, bleeding. Bleeding, it can be caused due to dilutional coagulopathy, or the prostate tissue can release the thromboplastin, which can cause DIC, disseminated intravascular coagulation. And also urokinase will be secreted, that is a plasminogen activator. It will activate into plasmin and that will cause the primary fibrinolysis. And
Surgical complications.
Bladder perforation can be
and
there.
capsular tear.
Is there any newer techniques which can reduce these complications, which you are talking about TUR, newer techniques of surgical techniques?
Newer techniques are laser TURP is there. Laser TURP with holmium laser also, HOLEP, holmium laser enucleation of prostate. It is using holmium, yttrium, aluminum garnet laser, which is having a wavelength of 2140 nanometer. It is used to the light energy is converted into heat that will vaporizes that prostate tissue and also coagulates the blood vessel. So the bleeding risk is very minimal with the laser form. So and if the bleeding risk is minimal means the absorption also will be low and the TUR syndrome will be prevented. And next one, it is photoselective vaporization of the prostate. The 532 nanometer light is used and it is selectively absorbed by the hemoglobin-rich prostatic tissue. So it is not dissipating into the environment. It will vaporize only the prostate and the bleeding risk will be less. And newest technology is aqua ablation of the prostate, that is using the robotics and ultrasound guided. It is specific precise cutting of the prostate gland using the high frequency pulsed normal saline jet infusion that can also minimize the bleeding. And
which other clinical situation can mimic the TURP syndrome? Like picture.
Are you doing any operations like that in your theater? Or?
PCNL, the percutaneous nephrolithotripsy can be there, and
hysteroscopic
hysteroscopy. Then hysteroscopic, endometrial resection. Then and also URSL,
rhinoscopic lithotripsy using irrigation solution.
Mainly the hysteroscopy. Why?
Basic difference between this hysteroscopy and this TUR surgery?
There's a patient posted for both surgeries are different. That is in age group. That is for
one is male and other is female.
Female, and also the one is elderly age group, and the hysteroscopy is usually done in reproductive age group. And the patient physical status also differ. In elderly, the patient is cardiopulmonary compromise is more, and in hysteroscopic patient, the patient having a good cardiopulmonary reserve, so the symptoms will be delayed, and patient can compensate the changes for some time.
So we early detection will be in the old age group that decompensated, so they will have the symptoms very soon, but the young age they will compensate for the problem, and the symptoms will be occurring later for young age during hysteroscopy.
Your syndrome is done for the patient. The other one is for infertility treatment mostly.
Treatment.
So the mother has to survive for the to deliver a baby, no, is it not? So complications.
If your
cannot-
patients get the glycine toxicity, like has transient, the patient is complaining, I can't see anything. How are you going to manage this patient?
First, it is a transient blindness, so reassurance can be given to the patient, telling that it is transient and it will be okay within 24 hours. And second one, arginine can be given for the patient. That arginine, that the glycine will be converted into urea if arginine is present. So try giving arginine.
Right. It may not take much of the hours, so you can definitely reassure the patient.
Reassurance.
Time is over. Shall we conclude? So thank you, Dr. Paul Raphael and his students.
Yes, sir.
Doing this nice presentation towards the end of the day. Even the end of the day, the discussion was active, and wish you all the best.
Thank you, sir.
Thank you, audience, for the kind patient listening.
Thank you.